And it's great that you're paying back actually right now the community, since you got you studied actually medicine in Cuba for free, and all the medical schools over there is free of charge, which is fascinating actually compared to the US. I just like maybe gonna ask one question, and then I will give the chance for Professor Dr. Manson to lead actually the questioning part. We have heard and learned a lot actually from the Cuban model, but we want to know that, for example, like despite the cost, for example, per individual is still high compared to the living conditions of the Cubans, but who's paying for all this stuff, all these medical costs? Who's paying for this treatment? Who's paying for the pharmaceuticals, the medicines? We know that, for example, one of the presidents, Chavez, late president, he was get his treatment actually in Cuba from the cancers. So we just wanted to know more about this aspect. Yeah, thank you.
Well, it basically comes out of the public purse. It comes out of the Ministry of Public Health budget, and they pay for maintaining the facilities, they pay the doctors' salaries, they pay for the medications. Where does the money come from? It partly comes from taxes. There are taxes even in Cuba. Apparently they can't be avoided. And they also come from some of the remittances from Cuban doctors working overseas, so that certainly helps to sustain the public health budget in Cuba. In addition to that, Cuba, because it has developed a viable biotech sector, is able to export a lot of its products, a lot of its medications abroad, and a lot of revenue comes into the public health system that way as well. Do you want to add to that,
The other thing
Lillian?
I would add, the only thing I wanted to add, I obviously don't know what the billing situation was for President Chavez, but I will tell you, as a foreigner that was in Cuba, that was a resident, but then lost her residency when she was graduated, is that foreigners have to pay for their care. Now, the price that they have to pay is significantly cheaper than in the United States, and so or other countries, and lots of people travel for that care. However, they do have to pay separately and differently and exponentially more than a Cuban resident or a Cuban citizen would.
Thank you very much, Dr. Laramé and Dr. Holloway. This is Spiro Manson from Colorado, and I mentioned Colorado and also the fact that I work with American and Alaska Native communities around the country, and particularly with tribal health programs and the Indian Health Service, looking at the links between those particular healthcare settings, which are largely acute care oriented, and several model examples of their collaboration with medical schools. So my question is this: in Colorado, we have a very sophisticated family medicine residency program that prides itself on outreach to a variety of different kinds of settings that would echo some of the features that were described here. So my first question is, what aspects of this particular initiative do you think have parallels to, but also unique contrasts with some of those types of advances that I think the more conventional forms of medical education, particularly in primary care and family medicine, are taking today, and what additional lessons are there to be learned in perhaps considering more fully the Cuban model? And then the second question I have is, how do you think about, well, let me ask that question first, and I'll come back to the one that springs from Indian Health, because did I hear you correctly saying you're working with the Navajo Nation too?
We're just beginning.
Yeah, okay.
Do you want to take a shot at that, Lillian?
Yeah, I don't know much of this. That's what I was actually trying to say in my presentation, is that my first experience with medical education here was really more when I was in residency, just participating in training of medical students. So my understanding of it was probably very one-sided. It's limited to where I went to residency. So I don't know what they're doing there. But I will tell you that some of the presentations that I've heard today, or even just in running in circles of global health and health disparities, I think you will find that anyone that wants to attack social determinants of health, there's probably not a huge difference between one way of attacking it and the other, in the sense that we all understand that this is a much bigger problem than we initially thought, and that you have to really kind of have outreach and get into the communities in order to figure out the way to cure it. Probably the largest, the biggest things that stick out in my mind as to what Cuba brings to the table that's different. Well, actually the presenter before us was talking about going to the community and taking from that community and having them. And I would tend to say, for themselves. So they had a set of problems and certain cultural strengths, and they use those in order to meet the needs that they had. So there will, whatever differences there are, will probably be slight, and probably will be really geared towards that, attending to that culture and that community that they have in Cuba and the specific conditions that they have there. I do think it is unique. As much as I underplayed it on this presentation, it is unique to be medically raised in a place where access to care isn't an issue. And probably of all the different unique ways that I see to address social determinants of health here, that's one of the largest ones that just we kind of keep running against, because now it is the least common denominator, and you still have to figure out how to pay for things. And then the other thing, again, that I don't think is 100% unique to Cuba, but I think is a very important point, is where you're drawing your students from. We heard about that in the previous presentation as well. Like, if we want to help these communities and make a difference in these communities, we have to draw people from those communities. It's not just outreach and, plop down care to someone that you see as separate or foreign. It is being involved with that community and sometimes taking people from that community. I don't know if that answered your question well.
Were you talking about the system in general, or medical education in particular?
Well, let me, as I've been listening today and have been thinking about this, I'm wondering if we're faced with two interesting and tough choices. One is obviously the attempt to integrate the lessons learned from these innovative social, in some cases experiments, sometimes not experiments, with some really remarkable outcomes, but they require an investment and a retooling of vision and ways of doing business that many of the existing conventional settings probably are unable to step up to do. So, so this notion of holding out for ourselves the goal of integrating these things into the existing medical education or other kinds of health education establishments poses some really interesting challenges. On the other hand, then I'm beginning to think, well, the old saw about, would you rather do something in a mediocre fashion in all places, or would you really like to have pockets of excellence in which these kinds of things are done extremely well in a limited number of places? And so I find myself listening today that maybe that's not such a bad model, and that asking everybody to do something adequately is one pathway, but maybe figuring out ways in which to incentivize and resource places of excellence that can do this really well may be an alternative to consider.
Well, I think one of the things that's unique about the Cuban model is that health is a human right. Health is a right. And so everyone needs to have access to the same level of health and care as everyone else. And that's another one of the unique qualities of the Cuban system, that the model that I showed you with the polyclinic and the doctor-nurse office, and that Lillian described in some detail, is found everywhere in Cuba, and it looks the same everywhere you go. And everyone has access to it, and everyone gets the same level of care. Now, there are financial, technological, and other constraints to that level of care. But in terms of the excellence of the training and the dedication of the professionals who provide that care, no one questions that. You'll hear Cubans complain about the lack of advanced technology, but you don't hear them, complain about the care that they get from their doctor.
I'm sorry, I have to interrupt this wonderful discussion, and I now want to go to Cuba. I always did want to go, but I really want to go now. And we're going to move on to the next session. Thank you very much.